Hello, everyone. Thank you for joining our webinar today on HHT and pregnancy. So I'll hand over to Sophie, who's the chair of the HHT working group and also one of our speakers today.
Thank you very much, Treasure. And good afternoon to all of you. So I'm Dr. Sophie Dupuis-Girod. I'm a pediatrician and a clinical geneticist. I coordinate the French HHT reference center, and I'm the chair of the HHT working group within Vascular. I'm very pleased today to present this webinar dedicated to pregnancy in HHT and to introduce the speakers. First of all, Professor Olivier Dupuis, who is an obstetrician and gynecologist working at the Hospices Civils de Lyon. He recently published 2 articles on pregnancy in HHT and is an expert for pregnancy in HHT. Then Professor Elisabetta Buscarini, who is a gastroenterologist working in Italy at the Crema Hospedale, who will talk about liver complications in HHT. Dr. Sanne Boerman, pulmonologist working at St. Antonius Hospital in the Netherlands, will talk about pulmonary AVMs in HHT. And a particular thanks to Paolo Federici and Luisa Botella, the 2 HIPAG co-chairs, who will moderate the Q&A session. Thank you. So let's go on with the first talk.
Hi, everybody. I'm Olivier Dupuis from Lyon, as Sophie just said. I'm very pleased to be with you today. Just to tell you that I have no conflict of interest. And so the question is, let's just have a look at this slide. How risky is it to be pregnant today or to deliver? And let's compare what you see on this slide, which is the civilian aviation risk to die and the obstetric risk to die in a developed country as France. When you compare, when you put the ratio between both, you see that it's 800 more risk to be pregnant or to deliver. So what does that mean? That means that there is a room for improving our practice. So first, if you have HHT, is pregnancy possible? Of course, it is possible. Maternal death rate is in the literature is less than 2%, 1.24%, but probably with a bias. I think it's less than 1%. And maternal life-threatening events are less than 10% of pregnancy. So you can see on this slide that pregnancies with HHT are high-risk pregnancies, but more than 90% of those pregnancies are okay. So the second question is, I have HHT, I discovered that I am pregnant, so what should I do? On this slide, you see 3 main studies, and what do they tell us? They tell us that more than 60% of cases, in more than 60% of pregnancies, obstetricians do not know that the mother has HHT. So what you should do, of course, as soon as possible is take an appointment with an obstetrician in a tertiary referral maternity hospital and tell your obstetrician you have HHT. That seems obvious, but I think it's not done in every case. Why you need to do that? Because you need to go from the left side of this slide to the right side, which means that you need to increase the follow-up when you are a high-risk pregnancy. In this slide, you see on the left side that it's a doctor who follow you like a low-risk pregnancy, meaning you have only, for example, 3 ultrasound studies, and that's not enough. When you are a high-risk pregnancy, you need to get more ultrasonographic studies of the baby. You need to have more clinical exam and so on. So now let's move to the other question. You have HHT and you want a baby. What should you do? As soon as possible, you should take a rendezvous at a referral HHT center. And that's why to do a full HHT checkup. That should include anemia, PAVM, hepatic AVM, and cerebral AVM. Those questions will be addressed soon by Professor Elisabetta Buscarini and Dr. Sanne Boerman. So let's go on. So I guess when you are pregnant and you have HHT, you wonder, will I be able to deliver vaginally? When you look at the studies, you see that more than 70% of pregnant women with HHT do deliver vaginally. So of course it's possible. Of course it's possible, but it's not sure. It's like in every pregnancy, and even in HHT-free pregnancy, you are not, of course, sure to deliver vaginally, but it's possible. Then another question that you can ask yourself during pregnancy is, with HHT, will epidural analgesia be possible? This is an important point because pain relief and avoiding general anesthesia are two main interests of epidural analgesia. So in these slides, you see that on the right column, you see that spinal hemorrhage really does not exist in HHT pregnant patients. You see in every studies, Chevlin, Gussem, and our study, there is no case, not one case of spinal hemorrhage during HHT because of an epidural analgesia. So you can perform a regional anesthesia during delivery if you have an HHT. But what you see also is that only 50% of women got a regional anesthesia on Gussem studies, and only 1/3 in our study. That means that we have to improve, and doctors do not know enough the disease. Because the rate of spinal AVM are less than 1%, that's for sure. As I just said, no case of spinal hemorrhage following epidural analgesia have been reported. And why? Because spinal AVM are located in the subarachnoidal space, and when you got an epidural analgesia, the needle does not enter this space. So there is no need to screen for spinal AVM, and epidural analgesia can be performed. Of course, if you want, as we've seen in the previous slide, if you want epidural analgesia to be performed, you need to provide a letter from an MD working in an HHT reference center. He will write a letter for you. He will give it to your maternity team. And you should also meet the anesthesiologist during the second trimester to address this question with him and to make things clear as soon as possible and during the second trimester. Another question is, during pregnancy, which clinician should perform your ultrasonography studies of your fetus? And I think because there are cases in the literature that are reported of fetal PAVM diagnosed during pregnancy, it's better to get the ultrasound performed at an expert ultrasonographic center. Okay? Why? Because as far as ultrasonography is concerned, when you practice ultrasonography, you will only discover what you look for. If you don't look for fetal PAVM, you will not find them. So if you want to find fetal PAVM, you need to look at them. Finally, what are the top priorities during pregnancy? This is also quite obvious, but not always. For mother, it's to get an healthy mother and respect the principle that the mother is first. What does it mean? That means that in case of life-threatening events, sometimes you have to proceed to delivery to be able to cure the mother, and that will maybe lead to induced preterm delivery. But mother first is very important, of course, obstetric concept. Then for the child, you need to have an healthy child, of course, and the goal is to reach 36 weeks of pregnancy. You have to know that when you have reached 36 weeks, then the baby is going to be okay. And of course, we also use antenatal corticosteroids to prevent respiratory distress syndrome in case we expect preterm infants. Finally, is there any other requirements during pregnancy? So this leads to this question. When a woman delivers her first baby, which change does she feel? This applies not only for HHT patient, but for every pregnant woman. Well, before delivering the baby, she was a woman, and after she became a mother. Before she had a husband, and after her husband will become a father. So in every pregnancy and after the first delivery, this will induce a kind of identity switch that will recall all the family history. And you have to be aware that this can lead to what I will call a psychic storm, and of course boosted in case of genetic disease, because you have a 50% risk, as you know, of inheriting the condition. So my advice is involve the psychologist during the second trimester and after. What I will conclude is you have to screen before pregnancy. You have also to learn the red flag symptoms that will be addressed soon by the other speaker. And you have to be followed by doctors working in tertiary centers and also care about the soul of the mother. Because there is actually, again, lack of information on symptoms of HHT with MDs. There's lack of HHT diagnosis in women of childbearing age. There is also lack of pulmonary AVM screening. And as I said, HHT pregnancies are high-risk pregnancies, and it's important to avoid all the problems when they can be avoided. So you have to, before pregnancy, screen patients, inform on this high-risk situation, and in case of red flag symptoms, in utero transfer in an hospital with a surgery unit and a transfusion facility, so it means an university hospital, should be performed. During pregnancy, we have to monitor the oxygen saturation. This is very important. In case people have hepatic AVM, we should monitor the cardiac output and cardiac ultrasonography. You need to look in case of ischemic cerebral or ocular stroke for paradoxical embolization and perform cardiac ultrasonography. In case of bleeding of PAVM, we have to perform a pulmonary embolization that can be performed during the second or the third trimester. You need also to use prophylactic antibiotics, for example, in case of dental procedures. And as I said before, you need to involve, of course, the anesthesiologist and the psychologist as soon as the second trimester. Finally, during delivery, you need to get antibiotic prophylaxis in case of PAVM. You need to avoid a prolonged second stage, which means that we will ask the woman to push a maximum of 20 minutes. You need also to avoid Valsalva maneuver, means to push with the mouth which is open. And in case of general anesthesia, you need some technical point to be respected. That's for anesthesiologists. So finally, you need to follow the guideline, the 2020 guideline. And that's it. Thank you for your attention.
Okay, thank you very much. That's a perfect timing, I think. And so I'm going. Thank you. Now I think that we will move on with pulmonary AVM, and thank you to Sanne Boerman for talking about pulmonary AVM during pregnancy.
So thank you. Can you see my screen? Yes. Okay. Hi, everyone. I'm Sanne Boerman. I'm a pulmonologist and working in the Netherlands in an HHT expert center. And I would like to tell you something about HHT and the lungs and what to expect in pregnancy. So what will be discussed is what are PAVMs and why do they matter? How to screen for PAVMs in pregnancy? And what do the guidelines tell us? So first, what are PAVMs, pulmonary AVMs? It's about direct connection between lung arteries and lung veins. You see in here, in this picture, above is the normal situation with the pulmonary artery leading up to pulmonary capillaries, going into the pulmonary vein. This pulmonary capillary network has the main goals to oxygenate the blood and filter the blood. So microthrombi and bacteria get eliminated from the blood flow. And the picture beneath is a PAVM. You see here a direct connection between the pulmonary artery and the pulmonary vein. This way, the pulmonary capillary bed is bypassed and the blood flows directly to the pulmonary vein. So the blood doesn't get filtered and doesn't get oxygenated in this area. So most frequently it's without symptoms. But it can be with symptoms, and the symptoms are shortness of breath, reduced exercise capacity, cyanosis, so blue fingers, nose or lips, clubbing, or high hemoglobin levels and migraine. Or they can present with a brain abscess or a stroke in formerly healthy patients. So there's a strong connection between PAVMs and HHT. Up to 15 to 50% of the patients with HHT have PAVMs. And in HHT type 1, it's more common than in HHT type 2. Here you see another picture of a PAVM. So picture A is normal, the vascular structures of the lungs. In B, you see the PAVM with the sac. This is the pulmonary artery leading up to the sac, and this is the pulmonary vein. And in picture C, you see a complex PAVM with more than one feeding artery. So, and what happens in pregnancy is that you get an increase of blood flow, more than up to 40% by the time of 28 weeks of pregnancy. And also the hormonal influences make that there is a growth of PAVM and that they are more at risk of bleeding. So people with untreated PAVMs have a higher risk of having an ischemic stroke and a brain abscess. So in general population, we advise people to get the PAVM closed by embolization if possible, and also to use prophylactic antibiotics to avoid the risk of the brain abscess when people get a non-sterile intervention like a dental procedure. And in case of untreated PAVMs during pregnancy, the pregnant HHT patient have a higher risk of enlargement of the PAVM, rupture of the PAVM, leading up to coughing up blood or blood loss in the chest cavity, having an ischemic stroke or lower oxygen levels. Complications occur mostly in the second or third trimester. The rate is estimated in recent studies up to 17% of non-fatal complications. And fatal complications occurred in 2% of the HHT pregnancies. And the most severe complications occurred in patients who were not screened or were not treated for PAVMs. So screening is key. Red flags during pregnancy are sudden shortness of breath or chest pain due to bleeding, unexplained shortness of breath, coughing up blood, experiencing abscess, cerebral or systemic, a stroke, or progression of migraine. Those are very aspecific symptoms, but when you have HHT and experience any of these symptoms, you should seek for help. So how to detect? In general, it's you can start with a transthoracic echocardiogram with contrast or a CT scan. And in pregnancy, it's preferred to screen before getting pregnant. And if you are pregnant, found out you are pregnant and have not been recently screened, it's advised to start with an echocardiogram or a CT scan, depending on the local expertise of your center. The timing is after the first trimester when all the organs are developed. We prefer to do it early in the second trimester. So if you have a PAVM that has to be treated, that you can treat it in time. So here you see a CT scan with a PAVM in here and also here. The CT scan in pregnancy, it's a low-dose CT scan with low-dose radiation and no intravenous contrast. And there are no known health effects for the baby at this level of exposure. So the contrast echocardiogram is a little bit longer to explain. It's the contrast is a mixture of saline, blood, air, and we mix it into microbubbles. Microbubbles are injected through the vein, and then we see if the microbubbles pass through the capillary bed. So in here you see microbubbles, not very micro, but going into the right heart, into the pulmonary veins. And in a normal situation, there should not be any passing through, and there should not be any bubbles on the left side. But in case of a PAVM, it can pass through. You see bubbles on the left side. So that's a suggestion of a PAVM. So it's basically about counting the bubbles. You see here a picture of an echocardiogram. And here the right side of the heart, here the left side. So the bubbles will come into the right side, and there should not be any bubbles or just a very few bubbles on the left side. Here you see grade 1, bubbles on the right side, and then very few bubbles on the left side. Grade 2 is up to 100 microbubbles. You see them here. And grade 3 can even be counted, more than 100 bubbles. So there's a strong correlation between shunt and CT findings. If you have a grade 2 or grade 3 shunt, there's a high percentage of patients who have a PAVM present on a CT scan. There's also a strong correlation between shunt and risk. The risk of a cerebral manifestation like ischemic stroke or brain abscess is there when you have a grade 2 or grade 3 shunt. So patients with a grade 2 or grade 3 shunt are advised to get a CT scan because of the high percentage of treatable PAVMs. So how to treat them? In general, if the feeding artery of the PAVM is large enough, it's advised to do embolotherapy by an experienced radiologist. The success rates are high, up to 90% closure seen at the CT scan after 6 months. In case of persistent perfusion, you can do a repeat embolization. The main goal of the treatment is to limit the risk of cerebral complications. And in pregnancy, you should perform direct treatment if there are symptoms, so bleeding or neurological. And when there are no symptoms, the treatment is advised to do in the 2nd trimester. You should always weigh the risk of treatment against the risk of no treatment. But case series demonstrated that there is an elevated risk of complications from pulmonary AVMs during pregnancy. And there's a low risk of imaging and embolization in the 2nd trimester. So you see here a couple of pictures of this treatment. With the angiogram, you see here that there's a plug placed, but there's still perfusion of the PAVM, and then afterwards there's a coil also placed, and then afterwards you don't see any perfusion of the PAVM. And you see, this is the picture after 6 months, that the sac is also shrinking. And here 2 pictures. This one is a PAVM, and then afterwards you see a closed up PAVM. Here you see PAVM with a large draining vessel. And here closed up. So last part is the guidelines, what to do in pregnancy. So already mentioned the international guidelines that we use. The advice in pregnancy, as stated in these guidelines, is that pregnant patients with HHT who have not been recently screened and or treated for PAVMs should be approached as follows. In asymptomatic patients, you should perform screening with either TTCE or low-dose CT scan. The CT scan should be done early in the second trimester. And when symptomatic, you should perform low-dose CT scan in any stage of the pregnancy as clinically indicated. PAVM should be treated in second trimester. In case of untreated PAVM, or in case of no recent screening, you should be treated in a tertiary care center with a multidisciplinary team. Consider the pregnancy as high risk for hemorrhagic or neurological complications. And in case of previously treated PAVMs, untreated PAVMs, a shunt grade above 2 or no recent screening, you should use antibiotic prophylaxis before non-sterile procedures, such as a dental visit with a molar extraction, for example. So, in summary, screening for PAVMs is key. The advice is to screen for PAVMs before pregnancy. And if pregnant, screen for PAVMs in the second trimester with CT or echocardiogram, if not recently screened for PAVMs. And in case of untreated PAVMs or not screened for PAVMs, consider as high-risk pregnancy, treat with embolotherapy in the second trimester, delivery in tertiary care center, and use of prophylactic antibiotics in case of non-sterile interventions. So, thank you.
Thank you, Sanne, for this very clear presentation. So let's go on with the hepatic AVMs and Elisabetta Buscarini. Are you going to share? Yeah. Yeah, perfect. Thank you, Elisabetta.
So, hi everybody. It's a pleasure to go on in this webinar with liver vascular malformations in HHT and particularly during pregnancy. First of all, let's have a look at what are the liver vascular malformations unique to this condition. First of all, take into account that they are very, very frequent in patients with HHT. From 40% to 70% of HHT patients can harbor this kind of malformations in the liver. And what is striking is that they are mostly women. This is very particular as we are speaking about an autosomal condition, but the fact is that we expect liver vascular malformations and especially the severe one in women. And generally in women that are aged between 45 and 55. So what is really typical is to have liver vascular malformations in a woman in her 5th decade. That's the first very important point to keep in mind in this topic, subtopic of HHT. Second, what is, when we say vascular malformation, in general we mean an anomalous vascular connection that in the liver can be either between arteries and veins or even vein to vein. And in the liver of HHT people, we can find either really teeny tiny vascular malformations that are really negligible from the clinical point of view, or huge vascular malformations that can have, do have implications on many organs in the body, mainly on the heart, but also on the lungs, on the brain, on the GI tract, and even on the nosebleeds. Because there is a spectrum of clinical manifestations due to the liver vascular malformations, due either to the shunt mechanism, that is the shortcut between arteries and vein, that lead to a progressive overload of the systemic circulation and therefore to the cardiac and circulatory overload up to potentially a high output cardiac failure. If the shortcut is between artery and portal vein, then we will expect a progressive overload of a portal vein and mesenteric circulation up to portal hypertension and its manifestations. If the shortcut is veno-venous, then we can have encephalopathy, that is a brain suffering due to the anomalous passage of metabolites directly to the systemic veins. Then there is a second important mechanism if we have this shunts in the liver, that is a flow derangement to the liver parenchyma that entails the formation of nodules within the liver, either as focal nodular hyperplasia or as nodular regenerative hyperplasia. And then there is a third mechanism, very important to be reminded, due to the presence of vascular malformations in the liver, that is the steal to the biliary tree, inducing a chronic ischemia, then cholestasis, or even ischemic cholangitis, or a steal to the mesenteric vessels entailing mesenteric ischemia. These three are the main and most ominous manifestations due to liver vascular malformations in HHT. If we speak about pregnancy and we bear in mind the physiological pregnancy hemodynamics already explained by Professor Dupuis, we have to remind that the cardiac output is increased by 30–50% both during pregnancy or during the delivery and postpartum period, and how these physiological changes combine with the presence of liver vascular malformations. First, we have to think that although severe liver vascular malformations in childbearing age are rare, pregnancy may impact on the clinical threshold, shifting from an asymptomatic condition to an overt cardiac failure. Because in presence of these shunts in the liver, the high blood volume shunts directly to the right heart. And this entails a further increase in preload and cardiac output, and therefore a further elevated stroke volume and heart rate. And therefore, with the progression of the pregnancy, it can lead to an overt cardiac failure, with the dyspnea as the most common presentation symptom that, unfortunately, it's a very aspecific symptom common to many other conditions in pregnancy. That said, we have to remind that, fortunately, most pregnancies in HHT women with liver vascular malformations can proceed normally. We have published 2 series of uneventful pregnancies back to 1997, 31 uneventful pregnancies in 10 women, and in 2011 we could demonstrate in 155 pregnancies not any symptom in any of them. But we have to remind that rare major complications can occur in this kind of situation. This is a very difficult to read table that I have summarized in this recap of 19 pregnancies in 17 HHT women complicated due to liver vascular malformations. They are reported in literature, and 4 of them were observed directly by us. Clinical presentation in these cases, in 14 cases, cardiac failure, in 5, biliary ischemia alone or in combination with cardiac failure or portal hypertension. Mother age, the mean mother age at the onset of a complication during pregnancy was 34 years. And again, HHT diagnosis known before pregnancy only in 6 of them, only in 6 out of 19 pregnancies. Some of them, some of these women, of these 17 women, had previous pregnancies before the complicated one. And in 11, they were uneventful. 4 led to miscarriage, 2 to high output cardiac failure, and 4 out of 17 had no previous pregnancies. What is interesting to notice is the average gestational week to which we recorded the onset of signs or symptoms. That is 27th, that is the end of 2nd trimester in the average. You see from 12 weeks to 36. And which are the signs or symptoms? Typically dyspnea, abdominal pain, edema, or anasarca. The delivery was induced in the average at 32 32nd gestational week. And what was the mother outcome for these complicated pregnancies? It was 2 peripartum deaths. 3 women required liver transplantation postpartum with a good outcome, and in 13 a good outcome was recorded. Fetal outcome 2 deaths, and in 12 cases a good outcome. So, if we include either maternal or fetal death or postpartum halt, we have to underscore that there was a rate of severe outcome for these 19 pregnancies in 26% of cases, that is 1/4. And 2 patients more had liver transplantation 5 and 20 years respectively after pregnancy because of hepatobiliary necrosis and complicated portal hypertension. The immediate and later outcome for liver in these 17 patients was liver transplantation in 1/3 of cases. And therefore we have to imagine that complicated liver vascular malformations during pregnancy could herald a substantial severity of liver involvement with greater potential for end-stage decompensation. Were the 17 women aware of HHT before pregnancy? No, as I told you, this awareness was lacking in 70% of cases. And this is in line with the fact that HHT diagnosis is generally made with substantial delay, and it is often due to a complication. And another insight, the mean age of these women was 34, so very young. And we could imagine that HHT signs could be missed or be too subtle to be detected outside a HHT referral center. So, what to do before pregnancy in a HHT woman? If the diagnosis of HHT is made in a childbearing age woman, screening for liver vascular malformation should be advised as part of preconception assessment and in line of what is advised for all adults with suspected or definite diagnosis of HHT. If the woman bears severe liver vascular malformations, that is grade 4, then the potential for severe or even fatal complications of a pregnancy should be discussed with the patient as part of preconception counseling. And what to do if HHT is discovered during pregnancy? First, check liver with Doppler ultrasound, which is in the pregnancy or outside the pregnancy, the ideal technique. And assess also the liver vascular malformation severity. And what to do if severe liver vascular malformations are discovered during pregnancy? Grade 4 liver vascular malformation should always, first of all, lead to the search of HHT diagnostic criteria, as these kind of malformations are unique to HHT. And again, the most suitable imaging is abdominal Doppler sonography, very compatible with the pregnancy condition, and to leave contrast-enhanced CT only wherever this kind of expertise is unavailable. And the clinical management of this kind of vascular malformations in the liver depends, of course, on the patient condition. Is the patient asymptomatic or she has signs or symptoms? And that's very important. At which gestational week are we? Because as we noticed, the threshold of the passage from the second to the third trimester of the pregnancy is critical. In the in the absence of symptoms and signs of these vascular malformations, we can stay only on a cautious surveillance, either, of course, a clinical, laboratory, and Doppler sonographic kind of surveillance. If alarming signs or symptoms arise, typically dyspnea, abdominal pain, edema, or to the laboratory side cholestasis, then we have to be really intensive. Because the treatment for complicated liver vascular malformations in pregnancy has to be intensive and appropriate to the type of complication. And the pillar of this kind of treatment is, of course, the use of diuretics, titrated up to necessary dosage. We, of course, have to interact strictly with obstetrics to decide what is the allowed in the patient condition. We have to correct anemia and to use all the cardiological drugs that are necessary to correct, especially the cardiac failure. We have to deal very often in this kind of complications with infection that is due to cholangitis, and we deal, of course, with antibiotic, and we aim to the delivery as soon as possible. The modality of the delivery is, in all described cases, cesarean section under general anesthesia. We can discuss with Professor Dupuis this kind of obstetrical decision. What is interesting really is what happens to the high output cardiac failure after delivery. This is very reassuring because all the patients with a high output cardiac failure that have been properly treated have a satisfactory response to the diuretic therapy and tend to return completely asymptomatic in a few weeks or months. In the patients we could directly observe liver vascular malformations remained grade 4, didn't change after childbirth, but returned asymptomatic. Of course, patients, this kind of patients, should be followed strictly over time after pregnancy with clinical, biochemical, and abdominal US examinations. In conclusions, preconception diagnosis and staging of liver vascular malformations are important for appropriate counseling of these HHT women in childbearing age. Most pregnancies in HHT women with liver VMs are uneventful, but we have to remind that a timely diagnosis and approach to the complicated liver vascular malformations in pregnant HHT women allows proper management with significant impact on maternal and fetal outcome. It is important also to remind to schedule a surveillance after delivery for severe liver vascular malformations, and always, as always, to discuss management of complicated HHT patients with the centers of reference for HHT. Thank you very much for your attention.
Thank you very much, Elisabetta. And so I will conclude now with birth and with the baby. So what about the baby? And very briefly to conclude, because this webinar was about pregnancy, not about HHT in children. So what about HHT at birth? As you know, the risk of transmissions of the mutated gene is 50% for children. We don't perform systematic genetic screening at birth. And most of children are asymptomatic and have a normal life, then symptoms tend to develop in late childhood. So in all cases, a careful clinical examination at birth that includes measuring of oxygen saturations and looking for murmurs by pulmonary and cerebral auscultation is necessary at birth and during childhood. For asymptomatic children, pulmonary AVM screening by echo bubble is recommended before puberty, and cerebral AVM screening is still debated, as there is no evidence based for cerebral AVM screening, and transfontanella echo should be evaluated. So in all cases, it's a careful clinical examinations which is recommended at birth. So thank you for your attention. And I think that it's time now for questions and answers. So Paolo and Luisa, if you want to moderate this session, I don't know if you have questions. Thank you.
Thank you so much.
Yes.
Just before Paolo and Luisa go on to moderate, I just wanted to make a quick comment. So for the attendees, your mic has been activated. So if you have any questions, please, you can raise your hand, or you can also put your questions in the Q&A box. Thank you.
Yes, okay. Thank you very much. It was a really very interesting discussion, interesting webinar. I have taken some note. I would have one quick question for Elisabetta, because she spoke of abdominal pain, which is sometimes not diagnosis in the right way. Can you explain better? Because this is something important to know exactly what can be the abdominal pain and not related to HHT and not considered as other kind of illness.
Thank you, Paolo. Abdominal pain is one of the most common and age-specific symptom caused to access to the emergency room. So it's really nothing and nothing at all easy to understand. And especially in a pregnant woman, I would be curious to know the advice of Professor Dupuis. If a pregnant woman says, I have abdominal pain, it's again something very tricky. What is particular to the liver vascular malformations is that if the abdominal pain manifests and it is localized particularly to the right hypochondrium, one very important warning bell should ring for us, because it means really biliary ischemia. It translates the ischemia to the liver, which could progress until the ominous hepatic disintegration that have been described in literature for this kind of localization of the HHT. Or, more rarely, translate the ischemia to the mesenteric circulation. In any case, what has not to be done is to interpret this for biliary colic, which is usually done. One of these complicated pregnancies reported in literature was actually operated on for cholecystectomy at gestational week 20th, thinking of a cholecystitis probably, but it only complicated more and gave more problem than solution, of course, because it was the wrong diagnosis and the wrong interpretation for the biliary ischemia. So, abdominal pain in an HHT woman bearing liver vascular malformation should really ring a bell for increasing the attention to the liver.
Yes, thanks, Paolo, for this question. We just added a small comment. During pregnancy, uterine contraction, they give pain, abdominal pain, but it's intermittent pain. It's not continuous pain. You should never have continuous pain, abdominal continuous pain, abdominal hepatic pain, which is continuous. If it's continuous, you need to screen for another problem, doing the CT or an ultrasound. But there is no reason to get continuous pain during pregnancy. Intermittent could be contraction, but contraction are never continuous type of pain.
Okay, thank you very much. Treasurer, I don't understand how I can see if there are any questions. I think you can manage. I leave it to Luisa the answer question.
Okay, so I see that Alexandra has her hands up, so perhaps she can go ahead and ask her question.
Thank you very much for the great presentation. Actually, I have the question to the last presenter. In children, you said before puberty screening for the PAVMs. I have now a child who is 2 years old, and we diagnosed PAVMs. So I don't know, what do you mean by pre-puberty? How would you like to set the measure when to start the PAVM screening? And if you would do the same threshold for the therapeutic therapies like 3 mm, or would you be more conservative in children?
Thank you for your comment. Maybe Sanne, you will tell your opinion too. But in children, there is no consensus about the age for screening pulmonary AVM. So it depends, in fact, of country. What we know is that in asymptomatic children, of course, not in symptomatic children, but in asymptomatic children, we never observed complications related to pulmonary AVMs before puberty. That's the reason why in all cases we recommend screening before puberty, but we don't know when to start with a screen. In France, for example, we screen for pulmonary AVM after the age of 5 years old, but I know that it's different in other countries. And as it's not evidence-based, I think that it's not possible to write guidelines for that. Sanne, I don't know if you have any other opinion.
No, I agree. I think we screen with just measurement of the saturation and physical exam. And indeed, we have not seen in asymptomatic children any complications of the PAVM. But when a child does have a low oxygen saturation, that's the reason to go further with diagnostics and to treat the PAVM.
Yeah, then the child is not asymptomatic if blood saturation.
No, indeed. Yeah.
Okay. Is it
Thank
clear
you.
enough,
Thank you.
Alexandra?
Yes, thank you. That helps a lot. Thank you.
While we wait for other questions, may I ask to you, Olivier, Professor Dupuis, to come back to a concept that's very important for all of us non-obstetricians, that is the right, when you aim to lead a severely compromised patient to the delivery as soon as possible, what is the threshold for you for safety for mother and child?
I mean, the most important thing is to get a very good communication between obstetrician and anesthesiologist, because we work with our anesthesiologist who monitor, of course, vital signs, and we follow their advice. If they think that deliveries they will be able to get a better cure of the patient once delivered, then we deliver the baby. So it's really communication between anesthesiologist and obstetrician. I don't know if that answers your question, Elisabetta.
So there is no number, not saying let's go to the 32nd, let's go to the 30th.
Yes, as I said, 36 weeks is really the goal. When you deliver at 36, then it's okay.
Yeah.
But 32 weeks is already very good, because before 32 weeks there are fetus that died. After 32 weeks, it's very rare to get a fetus that will die. So if you can reach 32 weeks, then it's already a big cutoff. But then, as I said, mother first. So we are not going to take a risk that the mother is going to die if the situation is very high risk. But it's on a case-to-case basis, with a good communication with intensive care doctors.
Okay, thank you.
What is very important, of course, is to get the corticosteroid treatment when you expect to get a preterm delivery, because that's for pediatrician is very important, of course, because this corticosteroid treatment for the mother we give to the mother will reduce the risk for the fetus, for the neonate. So, of course, corticosteroid treatment is very important. And then, of course, the second concept is that you need always to maintain a good blood pressure. The blood pressure is vital for the fetus. That's why you have to be very careful about using diuretics, because diuretics could lead to fetal death. So diuretic will improve the mother, but will kill the fetus. And I've already seen fetus that died because of diuretic given to the mother. So you monitor the blood pressure, because of the baby, his oxygen is coming not by his own lungs, of course, but by the placenta. The placenta are the lung of the fetus. You should never forget that.
Okay, I have a question that is a real case. What about an obstetrician that says that to his patient that she cannot become pregnant because she has HHT, and she had the 3 pulmonary AVMs, but that were treated and embolized, and she goes once and again because it's the obstetrician that belongs to her health service, and the obstetrician says that by ethical reasons he cannot risk the life of the mother becoming pregnant. Well, it's a case of reproduction, attended assisted reproduction.
Well,
and,
yeah.
yeah.
I will say to him, then also you should ask her not to drive because she can be killed in a car accident, and not to eat because she could get a piece of meat in her lung, you know. And I know one thing: when a woman wants a baby, she will have a baby. What woman wants, you know, the proverb, God's want it. So if a woman want, I had actually the case. It was not with HHT, but it was with another disease. This woman, she had a rare disease and mucoviscidosis. No, anyway, she had a disease where every doctor in France said you should not get pregnant, and if you were pregnant, you should terminate the pregnancy. And she said, there is no way I will terminate this pregnancy. So they tell her, then go to Professor Dupuis because it's a desperate case. And she come to me, I follow her, and then she was pregnant. I did a cesarean section, and then she had a lung transplantation. And now the baby is 7 years old, and it's okay. If a woman, she wants a baby, she will have it. So it's really something you need to get in your mind, because the worst thing is to get this woman not to be screened, not to be followed up. So if she wants a baby, she will have it. You need to follow up, and don't because if she will have it. So I will not say there is a contraindication. It's very rare. Contraindication is essentially for hypertension. Pulmonary hypertension are very dangerous for the pregnant woman. But except for pulmonary hypertension, there is really no contraindication to pregnancy.
Yeah, this is a question that we are trying to deal in our HHT Spanish Association, trying to help this woman in conflict with the doctor, because then if the doctor says that he cannot attend the process of this woman having a baby, then we are asking for a second professional, a second opinion, because the pulmonologist and the reference center of HHT says that she can have, there is no contraindication, and that she can become pregnant and have a baby.
Yeah, Sanne, as a pneumologist, you can also tell what you think.
Yeah, I agree. I think patients who have not been screened and not treated are at risk. And if a patient is screened and it's we have clear what are the issues, and the issues are treated. Except Olivier, I agree with the pulmonary arterial hypertension is a very dangerous situation for the mother. But except for that, when a woman is well screened, it should not be a contraindication.
Then also, Luisa, you should be aware about medical legal issues, and sometimes doctors are afraid to be sued. So that can be avoided by writing letters. You can say to a woman, I think it's not a good idea to be pregnant because of this and this risk. But if you become pregnant, then we will do what we need to do. Because medical legal issues and the fear to be sued with lawyers, now it's become really a threat for doctors.
Yeah, I understand. We are trying to deal with this case. We hope that we will help this woman. Thank you. I think that we have more questions now from people. Maybe a question from Antonio Cerrone. Could it be?
Yes. Hello to everybody. I have a question for Dr. Boerman about the treatment of PAVM during second trimester. Do you use the same approach for no pregnant patients? And are there increased risk during second trimester for this procedure?
I thank you for the question. We use the same procedure for non-pregnant patient and pregnant patient, and a case series demonstrated that it's safe to treat during the pregnancy, and there are no elevated risks compared to the non-pregnant patient.
Yes, this is as long as you do it in an expert center, of course.
Yeah, thank you.
And Sanne, do you screen the baby during the procedure?
How do you mean?
Do you screen, do you put a cover to avoid radiation exposure?
Oh, it's advised not to.
Okay. And you said correctly, you have to balance the risk and benefit of doing that during pregnancy. Can you enter more in detail? Because it's a teaching webinar. It's important to leave the message that we wait case by case. Of course, it's not mandatory to embolize every PAVM we find during pregnancy, isn't it?
No, and it depends on the, I think, the shunt grade and the measurement of the PAVM. What the feeding artery, how large the PAVM sac is. So we do it patient by patient, on patient by patient basis, and the risks are like with any procedure, risk of bleeding because of it's an invasive procedure, and the risk in an expert center are not that high, but you should weigh the risk and the benefits before getting the treatment.
We have another question. I think that we had before that could it
Marcello.
be Marcello Vettucci? Marcello?
Yes. Good afternoon to everybody. First of all, thanks for this very interesting webinar. It's very interesting. I have two simple questions, if I can. I mean, as a result of this study, was it evaluated whether the pregnant woman should have a particular investigation compared to the normal? That's the question. The second one, have this recommendation been registered for sharing at European level? Did you hear me? Hello? Okay.
Yes, we hear you. Yes, I think it's different because you need, as we said, to screen before pregnancy for PAVM, for hepatic AVM. So that's an international recommendation now. So I think everybody agrees about screening before pregnancy. That's for sure.
And it's published. It's part of the guidelines, 2020 guidelines.
Okay.
Because when you look at severe events during pregnancy, as was reported in several studies, include our study, in 90% of severe events are related to complication of PAVM. So if you want to avoid life-threatening problem, you really need to screen for PAVM. This is really a very, very important major topic.
Okay, thank you very much.
Welcome.
If I can make a comment on this very important question and answer. One of the most important progresses that have been made over the latest decades in HHT management are to find an agreement, a shared position between the different centers and different countries and different continents also about the safest way to manage patients. And we all agree on some of these recommendations very strongly. So PAVM screening before pregnancy, of course, but for all adults, for all children with the condition that Sophie has mentioned. Screening for liver AVMs nowadays is broadly accepted from either part, from both sides of the ocean also. So that's very important to have the complete awareness of the patient situation so as to guide properly all the decisions and all the situations that can happen in all lives, including HST and non-HST people, of course.
Thank you. That's very important because for every patient, there is the right to have the same attention and the same protocol and the same help by independent from where he come or live. That's all.
If I may have another comment, there is my own thinking. I am thinking about those assisted reproduction processes where the woman has to be treated with the hormones so that they can have enough ovules to make the in vitro fertilization. How does this process of hormonal treatment may affect or may put in risk the HHT woman?
I'm afraid, Luisa, I don't have the answer for your question. But what I can say is that the age of the mother now is increasing, of course. And for example, I've got just today a patient which is 51 years old and which is pregnant and is going to deliver maybe in less than 1 week. And it's her first baby. So I think that your question need to be addressed. I'm not a specialist. As Elisabetta stated, which is very important, and Sanne too, the cardiac output is increasing, but it's increasing and on the second trimester. So the hormones, the doctors who do in vitro fertilization, they use all that at the first trimester, of course, not in the second trimester. So I don't think there is a higher risk. It's more with in the second trimester that problems are going to arrive because of increasing cardiac output. Because a woman has like 4 liters of blood when she starts her pregnancy, and she has 5 liters at the end of the pregnancy. So cardiac output is increasing, but not at the very, very beginning of the pregnancy.
Thank you. Thank you.
Just a quick one. Maybe we should also start rounding up. So just 2 questions that were sent by some of the attendees before the session. So the first question was, what is Vascuen's stance on systemized newborn screening for children of a parent that has received a diagnosis of HHT? And then the second question is a study of AVM in uterus necessary to prevent possible hemorrhagic complications during pregnancy or delivery, or with regard to increased likelihood of miscarriage? So we can answer both questions at the same time.
I can answer the second question about, if I understand, it's AVM in the uterus.
Yes.
So related to that, what you have really to understand is that the risk of PPH, which is postpartum hemorrhage during pregnancy, for every woman is 7%. So more than 600 women died every day worldwide of PPH. So it's 7%. So the risk, if you don't want to take the risk of bleeding, you should never be pregnant, because pregnancy and bleeding is kind of synonymous. Okay, so I think that HHT is not the problem. The problem is how you deal with the standard PPH. And I'm afraid to say that in 2024, there are still mistakes that are done because some doctors don't use checklists, And we used, of course, for something which is as frequent as 7%, we need to have checklists for this to deal with PPH. So HHT, there is no problem with PPH, no more problems than for every pregnant woman.
About screening, children's screening, I think is a very, very highly debated subject. And I think that I will not find a solution today. What we know that is that in asymptomatic children, so there is no proved advantages to screen for children. So, and in France, for example, the law, according to the law, we are not allowed to genetically screen children if it's not proved that it will improve his or her health. So that's the reason why we don't screen genetically children at birth in France. And I think that it's the same maybe in Europe. So I know that in other countries and in the United States, they screen children, particularly for cerebral AVMs. But again, it's highly debated, and I think it's not evidence-based. So that's my comment. I don't know if Sanne or Elisabetta, you have any other comments on that questions?
I agree totally.
Okay, thank you so much. And if there are no more questions, which I don't see any raised hands or questions in the Q&A box, I think we'll round up the session for today. So thank you everyone for coming. Thank you also to our speakers for today. Thank you. The presentation was highly, highly informative, and I'm very sure that all the attendees have gained something from this presentation today. So thank you, and looking forward to the next HHT webinar, and I hope to see all of you, our attendees at the webinar. Thank you so much.
Thank you to all of you. I know that Paolo has a comment.
Just one last word. Don't stop to get pregnancy because of HHT. I gave birth to 4 sons, and still fine. Sons and 65% because I have 3 over 4, which is HHT. So even more than 50% has been in my side. But I would like to have more, but now with the age, I'm over 51, and so I cannot go. No.
Okay, thank you.
Thank you so much, Paolo.
Thank you very much.
Paolo, for this important.
Thank you, Treasure.
Bye, everybody.
Bye.
Okay,
Bye.
bye.
Thank you.
Bye.
Good evening.